Thanks so much for coming out to join us for a conversation today. I see lots of familiar faces in the audience, which is wonderful. Most of I assume that people who knew me would just go do something else because you've heard all this before. But I am excited to spend a little bit of time chatting with you about what we're doing at FSSA and how we can even more closely partner for improving using data for outcomes and analysis. I want to start with a story. I start all of my chats with a story. When I started as FSSA secretary in 2017, so just celebrated my 2-year anniversary in this role, I had to go through an ethics hearing in order to continue being a doctor. Because that was one of the things that I said, hey, when I start this job, anything that's an appointed position in state government is the ultimate temp job. At any point, someone could walk in the door and say, yeah, we don't really like those shoes. You're gonna have to find a new job. So I wanted to still continue to practice medicine for a couple of reasons. One, I really like it. And two, there has never been a shift that I have worked in the emergency department where I haven't seen a family or a child who I could have in my other role in the office prevented from showing up at my doorstep. And so it's really good to keep it real. You make better decisions behind the desk when you get out from behind the desk on a regular basis. So as I sat at my ethics hearing with a panel of individuals to talk to them about why I thought it would be really important for me to still continue to work a shift a week in the emergency department, they asked good questions and smiled and nodded and said, this is really, really wonderful that you want to do this. It sounds like it'll be really hard. And I said, well, I think it'll be hard, but I think it'll be great. I mean, I'm an ER doc, and so we're used to working weird hours and weekends and holidays and all the rest. And then there was this pause, and one of the gentlemen on the ethics committee said, so will you still do science? And I said, like perform science, like research, or read science like a consumer? And he said, both. And I said, yes. And so the concept of, obviously this was a really exciting thing for someone to come in as an agency head and still do science. And so what we've really been doing is the concept of we have a lot of things that we change every day. We have the ability to influence policy on a daily basis, and small changes when you're affecting 1.5 million Hoosiers suddenly are not small changes anymore. And so we need to do science. And when we make policy changes and when we build new programs and when we change things, or even when we don't change things, we need to have a culture of inquiry to evaluate how those changes are going. And then we actually need to keep looking over and over and over again so that we're doing the right things for the right reasons in the right places. Now, you'd think that that would just be baked into how we do things, and it's not. And one of the reasons that Connor is in his role, which is a totally made up job just for him, is that we have an extraordinary infrastructure to have a culture of inquiry already there. Our data warehouse for Medicaid is #1 in the country. We were awarded in 2018 the #1 digital government in health and human services for the United States. It's there, it's already there, and we've built out this extraordinary system. Now we just need to do it. And so what we're going to talk with you about is how we take this incredible infrastructure and we do science with it. And how do we continue to build a culture of inquiry, not only within our public sector, but then how do we connect that with the private sector, with academics, so that we can look at the changes that we make, hear feedback, and then pivot a little bit faster than what I affectionately call the speed of government. And so with that, I'm going to tell you just a little bit about how we do things in Indiana. We have a governor who is very practical, and it gives us an incredible roadmap as agencies to know where we're going. These are the things that matter to the Holcomb administration, and we call them our pillars, and we have 5 of them. The first is to build a great economy. The second is to build a healthy workforce. The third is to build a sustainable infrastructure. The fourth is to combat the opiate epidemic. And the fifth is to deliver great government service. Now, I often joke that FSSA is all of the pillars except for roads and bridges, but we do have 4,500 employees across the state. And so if you wanted us to build your roads and bridges, we could probably be harnessed to do that as well. But what we take the most seriously is this delivery of great government service, which is really our catch-all for everything that we do needs to be easy for the end user. It needs to be understood by the end user, and that's really where this culture of inquiry comes in. Now, what we build underneath those pillars at FSSA in particular is social context. And so we launched our Healthy Opportunities Office just a little over a year ago to be the theme that runs through the entire agency about how we do what we do. And that is taking social determinants of health out of the academic page where it lives currently and put it on the streets where it works. And so everything that you'll see today is all built around making social services and healthcare focus on the end point, which is our North Star, which is people, communities, and health outcomes. So you are the first folks, and I didn't necessarily intend for it to be this way, but welcome to our brand new, unveiled just last week, vision statement for FSSA. And it is, we went through the whole process of putting people in a room and locking the door until they came out with the words and phrases that would get you up out of bed and help you come to work every day. My sister works for John Deere. She is an ag engineer, and in 2011 she was invited to be part of the John Deere mission statement overhaul. And for those of you who drive John Deere tractors, you may recall that their old mission statement was performance that endures. What that means is we build a really good tractor. And that's a good thing when you're a tractor building company. It's good to build a really good tractor. But when they came out of that 2011 mission statement redesign, their new mission statement became to feed, clothe, and grow a growing world. So getting up out of bed to feed, house, and clothe a growing world. To come out and with that statement and build a really good tractor that then gets you there, that's what you really get out of bed for. So our new vision statement for FSSA, which you'll see on our website here in a couple of weeks, is what we want to reach. This is our aspirational statement, that all Hoosiers live in fully engaged communities to reach their greatest emotional, mental, and physical well-being. And we're going to talk to you for the next few minutes about how we're going to do that. So I'm going to turn it over to Connor for a few minutes because we have been really extraordinarily blessed in 2018 to double the number of competitive grants that we've received for the state. We used to be 49th or 50th for public health funding. And if you include FSSA's grants for this last year in that number, we're inching up on average. Now, average is not where we want to stop, but I'm pretty happy with not being last. And so in excess of $80 million of new granting to be innovative in these spaces within FSSA. And one of them was we were one of a few states that were chosen for the National Governors Association technical assistance on how to harness the power of data to achieve our state policy goals. And so, Connor, I'm going to let you go through that program.
Thank you. So, Indiana has a really good track record with the National Governors Association. There's actually 4 concurrent NGA projects going on in the state of Indiana right now. And that's a tribute to all of us. I think some of you have actually worked on NGA projects with me or not with me. Some are with the Department of Workforce Development, but the National Governors Association has historically said that Indiana is really good at working through these technical assistance programs and coming out with actionable things that we can take to the governor and recommend, something that will make a difference in the state of Indiana, whether that's roads and bridges or whether that's healthcare or whatever that may be. And so we applied for this. It was one of the very first things I did when I came onto the agency. Jared Linder, our CIO, sent it to me and said, we should apply for this. And I said, sure, it sounds great. So what that meant is there was 3 days in a row that I came in at 4 o'clock in the morning and I wrote from 4 to 8 and I just wrote it and got it done, because when 8 comes around, you can't get anything done anymore, right? The door starts revolving and we had to take care of everything else. So we got this submitted and we submitted a vision statement to the National Governors Association. And this technical assistance program was really for states that are pretty far along in terms of using data, whether that's cross-sector data sharing, so working with other state agencies to link Department of Corrections data to Medicaid data or DOE data to workforce data, so that we can better understand the populations that we serve and inform our policies and programs to do those things better. So we submitted this vision statement that at the end of this, we want to fully harness the power of data by fostering a culture of analytics or a culture of inquiry, including best practices for business intelligence, advanced analytics, and health policy research in order to achieve state policy goals and secure the well-being of Hoosiers, which ironically aligns pretty well with our new missions vision statement, but that was not an intent. This was written way before that. But I think that's because we all at FSSA have the same type of mindset of what we really want to do. And so we submitted this, it was awarded, they took 8 states total. Every state is working on different things. We kind of talked about how we are today very good at cross-sector data sharing. We have the Management Performance Hub, which many of you guys are familiar with, who has helped coordinate these relationships between the agencies, break down barriers to data sharing agreements, MOUs, and the legal mechanisms that we have to have in place to be able to share those for whether or not it was for reporting purposes or business intelligence and operational decisions or research. And so not everything we're able to do well today, but we have made significant progress in actually our model state in being able to do that across the agencies. So we will continue to do that. But one of the things that we've really focused on at FSSA is how do we build a data-driven culture. And the more and more I dug into this, when I came on to the agency, like Jen said, I kind of made this position up because I recognize some of these things listed here that we were missing. We have the infrastructure, we have a $30 million data warehouse that we run, and we have all kinds of data that we get from the State Department of Health and from Workforce Development and other departments that we have to use for transactional decisions and eligibility determination and those types of things. But what I felt like we were missing is actually the culture piece, right? We were missing, someone once told me that the simplest way to define culture is what people do when you're not there, right? So we have to get people to want to use data and it be naturally integrated into what they do on a day-to-day basis. So if the supervisor's not there, they still want to check the data before they make the decision, right? So I'm just coming off a cold too, so I apologize that my voice goes in and out. But so we're really focusing on that, and I've been trying to get my team, and I think it was opportunistic that I came in at the time that I did. I'm not a computer scientist, I'm not an IT professional by training, right? I'm a health policy person, and so I kind of joke, I don't know what Jen was thinking when she said, yeah, go run 100 people in a multi-million-dollar data warehouse, but I think it was perfect, and the reason why is because I'm not that person, right? There's a continuum of heavy IT, heavy data solutions, right? And end user business solutions. And we're really heavy on the IT side. They're good for privacy and security reasons, right? But I was so excited when I left, well, I wasn't excited, but I was thrilled when I left academia and I came over there. I have a salary that I don't have to worry about soft money, and I have access to all the data in the world, right? And then I quickly realized I have access to no data because it's not set up in a way that actually allows people like myself or people like yourself to do anything with it without spending 6 months to a year trying to figure out how to extract 500 tables out of our warehouse and do whatever you want to do for your specific research project. So I've been pushing the team to really focus on how do we restructure the data, how do we democratize the data, how do we get access, how do we get transparency, how do we make sure we're still meeting all of our privacy security requirements, but we're thinking about the end users and the people that can actually do the analytics and the people that have the good ideas. So we're building that culture and the data leadership piece of that. And then the decision making. I love the anti-HIPPO. I don't know how many people have heard what a HIPPO is, but it's the highest paid person's opinion. And so that's usually where data discussions stop, right? And you have to get the HIPPO to want to be able to use data to inform their decisions too. And if you can do that, then you've accomplished that piece, right? And so I think that's a really important thing. And then people have to not be afraid that the HIPPO is going to kibosh their idea when they say, well, do you know that for sure? Or have we tested that? Or do we know, can we look at the data? And then so that goes back to the culture, right? And so then organization and people, that's making sure that, like I said, the infrastructure is there. We had no SaaS licenses when I got there, 4,500 employees, no SaaS licenses. If you don't know how to use SQL, then you're kind of out of luck. And so I'm working to change those types of things to make sure that we really have the data architecture, the infrastructure, and the analytical tools available to those internally and externally that would want to use them to be able to answer questions. And then ongoing training for people. And then also making sure basic data quality and that kind of stuff that you guys don't, you want the end product once it's all cleaned and perfect, right? So we're working on all those things. It's not easy, but we're slowly getting there, I think. This is one of the first examples of how our work with NGA and this new data-driven culture and partnerships with the Department of Correction have led to some really meaningful changes to our policies and programs. And I don't have specific numbers yet, but I'm going to talk generally about it. So I believe it was 2017, a couple legislative changes happened that allowed the Department of Corrections to assist in the application process for Medicaid for inmates 60 days prior to release. And that was to make sure that when these individuals leave, they have healthcare coverage, because we know that healthcare coverage is, well, I think we would all agree anecdotally, and I'm sure the research is there too, it's not good for someone to leave the prison system with no healthcare coverage. They can't leave with their oxygen tanks and their durable medical equipment. They have issues with prescriptions. They end up right back up in the hospital. They recidivate very quickly because they don't have the support that they need in terms of their behavioral and mental health. And so we wanted to make sure that they got that coverage when they left. Turns out when we started linking data with the Department of Corrections and Medicaid, we're not actually getting them on or fully approved for Medicaid coverage when the day they leave, or even right thereafter. It could be a couple of weeks or even up to 30 days before they get coverage. So only by linking this data were we finally able to say, wow, what we thought we were doing, we didn't operationalize it in a way that it really met the outcome we were trying to get. So we're digging into that. We're trying to determine the total impact of how long it's taking and looking time to coverage to make sure that we can get that down to hopefully the same day. And so we're in parallel working on a new process with presumptive eligibility that would allow us to do that. It's a workaround to allow us to make sure that the person leaves that same day as part of the discharge process with coverage. We would never have been able to do that had we not worked with Department of Corrections. We had a data-driven culture. We had the data sharing agreements in place, and we were able to kind of work collaboratively. DOC is ecstatic with this, and so is the governor's office. So I think this is one of Jen's mantra, right care, right place, right time, and we were not giving them the right care at the right time because just a process needed to be improved, right? And if you want to talk about his performance.
So we have an incredible thing in Indiana called the Management Performance Hub, and it is a data bunker in the basement of the State House. And when I say bunker, I'm not kidding. Like, my badge doesn't get me in. I still have to stand outside and like bang on the door for the folks to let me in to MPH. Management Performance Hub is meant to be a central repository for data sharing. You would think that this happens everywhere in every state, and we're it. We're the only state that has a centralized space that, in a way that keeps things private and keeps us all out of jail, we can actually share and look at information across sectors. Now, what brought this to the forefront was tragedy. And Dr. Adams, who was health commissioner with me while I was deputy health commissioner, we were really lucky to be part of this process. And he says, never waste a good tragedy. And the good tragedy that brought this all to bear was the opiate epidemic. And what was happening as we were trying to build systems to work with Indiana's opiate epidemic, especially with the HIV outbreak in 2015, is that we were working on 2 to 3 year old CDC data after it had been cleaned and aggregated and sent to us. And we had already lived through 2012. And we're responding in 2015 to 2012 information. And so with the Management Performance Hub and its opiate subgroup, we've been able to build a real-time dashboard that doesn't just look at things like hospital discharges, which is a very small way to look at the whole picture, but we were able to build a dashboard that brought multi-agency data together in real time. So think about what happens if you get not only your reportable diseases, so hepatitis C clusters and overdose emergency department visit clusters, but also state police seizures by drug class. and also arrest records and pharmacy crimes all dumped together, geocoded, mapped, and sent to your email every day. What happens when you have that is that you can actually do something that matters and then see if it's working. And so out of this cross-sector data sharing with the opiate epidemic and our drug dashboard, FSSA was able to use our 21st Century Cures dollars and our state opiate response dollars from the federal government, which are in excess of $50 million, to build out programs to respond in real time to things that we're seeing happen on a daily basis. So if we have a cluster that hits our radar through our Essence dashboard and this dashboard in a place that hasn't seen a cluster before, we have a mobile response team that responds to that immediately and goes in and does an assessment of what the infrastructure is in that area, what they're lacking, and they look at 3 buckets. They look at what is the emergency intervention in place and where are those? Do we have a syringe service program if we're seeing clusters of hepatitis C? Do we need to think about getting those processes up and running? Does everybody carry naloxone in this particular area? So first responders, do we have EMS carrying naloxone? Are bystanders and community groups carrying naloxone? They can come in and do those things. Do we need to enhance treatment capacity for medication-assisted treatment in this area? And what kind of prevention programming is going on? And who are the stakeholders that need to be convened? And then that mobile response team can stabilize, build capacity, and then move on to the next cluster. And so these are the types of things that are happening. They're not future state. This is current state work that happens in this sector. Now, the fun thing about that opiate dashboard is that it's about to be flipped to you, so that the folks that are using and actioning on this data right now, this information, shouldn't just be us. It should be local government. It should be stakeholders. It should be researchers. It should be all of us responding together for these types of interventions, and then also the analysis of whether they're working and what we need to do better. So that's just one example of what the Management Performance Hub does and allows us to share together and make good decisions based on the right information. Because honestly, before we were building the plane while we flew it in 2015 to respond to this epidemic, we really did run blind. We had little pockets of information that we thought we were doing the right thing, and we built programs based on the best evidence we had available. But this is a very different day in 2019 and really changes the way that we deliver, again, public health and multi-service use for Hoosiers, just in this one particular segment. But MPH really has much more visibility into things like workforce development and how we work together to grow our economic processes. So we're really excited about having this tool available to agencies to get kind of out of our own lanes and really think about how we build solutions together. I also am going to just talk a little bit and brag on the team. We became the first state in the nation last September to make our Medicaid data open source. And so we have, I think, 29 data sets now. Yeah, 29 data sets that are de-identified, but they're just out there. You can click on our data hub and you can use these for analytics, helping. We don't have the corner office on good solutions, and we like to crowdsource. And so these data sets help us do this together. And we have built in multiple different layers so that this is just, I mean, my mom can go into, she wouldn't want to, but she could go in and take a look at our open source data anytime she wanted to. But there's a layer just beneath that if you are a researcher and you want to get a little bit deeper in, we make it really easy for you to do that. And that really is the manifestation of our goal of collaboration. The goal of we're running around keeping the trains on the tracks. We got to get people their services. We've got to get people Medicaid coverage and SNAP and TANF and aging services and disability services and Social Security and all the rest. And those trains need to run on time. But we also need lots of help on how we can do it better. And we don't do that by ourselves. We do that with you. I'll turn this over to you on talking about our business intelligence.
So So when I came in as well, I tried to assess what we do as an agency for data, right? And it kind of comes down to three things. We do state and federal reporting requirements, and those are the things that Jen's talking about, keeps the lights on. CMS and Food Nutrition Services, they want to see some reports and things to justify the money that they're providing to us to support the programs that we deliver to Hoosiers. But there's two others, and one is business intelligence, which is real-time or as close to real-time information to help with daily and operational decisions to improve our programs and policies, right? And the third is advanced analytics, which is kind of probably more what you guys are interested in terms of research, predictive analytics, machine learning, AI, all of those things that can help us do a lot of things around waste and abuse or program integrity. We can allow machines to learn a lot faster than we can and detect patterns in the data to help us know where we should be focusing attention to really streamline processes, make sure we're really efficient and effective with our funds, and we're delivering the best possible care, the best possible services to our constituents. So one of the things that we wanted to do is make sure that all of our business intelligence, our key performance indicators, our metrics, align with those 5 pillars that Jen talked about earlier from the state of Indiana. And then also the things that we care about in Family Social Services Administration that align with that vision, and then align with some of the other things that we really want to make sure that we're doing well as an agency. What I love about Jen's vision is that she doesn't want to report on things that we're doing well, because we should do them well, and we'll continue to do them well. We want to report on things that we can improve on, or things that we know we need to be watching, and we need to make sure that we don't get any worse, and in fact we continue to get better at those things. And so this is a diagram that kind of illustrates the 6 programmatic divisions that really need to feed information to the secretary or to the executive team or the office of the secretary to make sure that we have a good picture of what we are doing as an agency. And so that kind of represents, we're in the process right now of redefining our key performance indicators to make sure that they align with those things, and then that they feed up into the decision makers that can do something with it, right? Here's an example of a potential dashboard that we're getting ready to implement, and this is an enrollment report that would be for Medicaid, and you would actually be able to look at real-time enrollment for OMPP, and the program director for eligibility enrollment would actually be able to click on counties and look at specific information. They'd be able to drill down. They would actually be able to drill down to the PHI level information and look at individual people. We would federate access, basically. She, obviously being the program director for enrollment and eligibility, would be able to have that type of access. We would not want the secretary having that kind of access, because she doesn't want to look at PHI on a daily basis. But we would try to make sure that we build these dashboards and BI tools that allow all of our directors, our division directors, our deputy directors, everybody in the office of the secretary, the information that they need to be able to, when they have to walk across the street to talk to the governor's office, they have those numbers that they look at on a daily basis. Right now we have some tools that are kind of disparate, they're kind of all over the place. We're trying to streamline all of that to make it the same look and feel and make sure that it all kind of feeds each other and works together. Talking to one of the HIP director in Medicaid, for example, we have a big dashboard that she looks at all the time, but she says, I look at 2 numbers, it's on the 3rd tab, and it's all the way down at the bottom right-hand corner. And so I said, why don't we take those 2 numbers and put them right in the front, right? There's no reason for you to click all over the place. So we're trying to do those types of things to make sure that we really have a good picture of where we're at, where we need to go, and how we're doing. This is a table that kind of illustrates how I'm trying to make this distinction within FSSA, what the difference is between business intelligence and reporting and advanced analytics. Because I think, as Jen mentioned, we're not the corner office of good ideas in research. We have a good matrix group of people who have a lot of experience in research. We have various, people from pharmacy and PhDs and clinical directors that have had very successful careers in academia and doing research. But they have other responsibilities to make sure that we get the right care, right time, right place, right? So how do we make sure that we don't lose sight of the advanced analytics piece? We want to make sure that we're answering questions, not what happened, when did it happen, who, and how many. For example, Scott County is a good example that I always bring up. As soon as that happened, we wanted to know how many people are affected, where is it happening, how many providers do we have in that location? And we needed that information as fast as possible to figure out how we were going to address this crisis. Then, as soon as we got that under control, people started asking the questions, could we prevent this in the future? What if we changed the policy? Would it make an impact? How do we make sure that we do X? What does that mean? So we changed the questions, and those are really those advanced analytics pieces that historically we have not put, we kind of crowdsourced that to the university, the universities. But I think we realized that we have to make sure that the infrastructure for analytics is available within FSSA because it makes for easier transfer of data. There's good data governance at FSSA that allows us to facilitate. I think a couple of people in this room actually emailed me today about data access. The answer is yes, if it's allowable. And I want to make it super easy as long as everyone's protected and you can get what you need. But we have to build some other things to continue to make that easier. So we're continuing to do that so that we can ask these questions. Why did it happen? Will it happen again? What will happen if we change X? And those are just a list of examples of how we operationalize those things. So want to continue to move that. I want to have a really robust reporting and federal reporting requirements. I want to have really robust business intelligence. And then I want to call on all of you guys to help us make a really robust analytics arm, which is not just going to be an FSSA. It's going to require all of our internal and external partners. And I'm committed to making sure that we have the right infrastructure in place and the analytics tools available to help facilitate that. This is just an example of what we're doing. There's somebody in the room who's probably not happy that I put it up here, but I think it's important that you guys see we are committed to building analytics layers and building the infrastructure to allow this to happen. And so we really want to build this enterprise analytics solution. I want to have, if there's 4,500 people working at FSSA, I want to have 4,500 SaaS licenses. I know that's we don't really want to do that, but we want to be able to make sure that anybody who has any ability to do analytics has the tools that how they want to use it. SAS, Python, R, Stata, SPSS, doesn't matter. And this type of infrastructure that uses the cloud would actually allow us to do that and make sure that we continue to build off of the warehouse that is the foundation of all the data and where we store it, and we build all the complex relationships to do all of our reporting. That's not the end all be all, and that's not the only thing. So we want to build other pieces and really turn into a data hub that allows us to bring in other data sources from ISTH, from the university, from wherever, and allow you guys to do more analytics on the back end. I'm going to let Jen talk about this one because this is exciting.
So this is how we wrap up this conversation and open it up for questions, which is the doing science that I started. I start those stories for a reason. They're funny, but they also inform kind of how we do what we do. So hepatitis C, as many of you know, is a big problem in Indiana. And not just in Indiana, but across the US, there are pockets of states that are in almost endemic hepatitis C numbers, and Indiana is one of them. Hepatitis C treatment has been revolutionized over the last decade, to the point where, even though it's not exactly the right word, we have a cure. It's technical, but it's as close to cure as you can possibly get with a medicine for hepatitis C. And those medicines are extraordinarily expensive, and when new extraordinarily expensive but important medicines come out onto the market, we have to figure out what in the world to do with them. And in the past, the way that we figured out what to do with them was to limit them to certain populations. So you manage your cost by managing your volume. And that's a pretty simplistic way to look at medicine, and it's a really bad way to look at population health. And Indiana historically does that really well. And so we limited hepatitis C medicines for certain stages of liver involvement, to certain type of doctors that could prescribe them. We had some really interesting caveats for people. You had to be like a good person to get hepatitis C treatment. Really bad stuff. Very embarrassing, actually, to be frank. And so as we looked at hepatitis C as an administration and as an agency, we said, you know what, the only way that we're ever going to get out of this is we're actually just going to have to make hepatitis C treatment available to everybody. Because even though in those of you who know about Hep C, about a third of folks will actually clear this virus on their own. We don't know who they are. We don't know how long it's going to take. And by waiting to see who they are, in the meantime, because hepatitis C is spread through injection drug use, about however big that network might be, those folks get hepatitis C too. So maybe this one person clears, but the whole network, and then we've got we move into logarithmic math when we talk about the volume of folks with Hep C. So we decided as a state that we were going to treat hepatitis C a little bit differently, and by a little differently, like a lot differently. And so we said, this is a really complex medicine, but we want it to be easy for people to access it. And so we're going to take this medicine and we're going to take it into Medicaid. And so if you are a Medicaid member and you have hepatitis C, there's one way to access the medicine. You're going to get it the same way every time. We're also going to build out a program called an ECHO program. ECHO is a train the trainer module, so that if you're an infectious disease doc, yeah, of course you can treat hepatitis C. If you're a hepatologist, you can treat hepatitis C. But if you're a rural family practice provider in the middle of nowhere, Indiana, and you enroll in an ECHO program, you can treat hepatitis C too. And that'll be really fun, and we'll get a whole lot more folks treated. And so this year in our budget, if you see our Medicaid forecast, we actually have an entire line item in the Medicaid forecast just for hepatitis C treatment, because we think it's that important to really attack it now so that we don't have to attack it later. So by moving hepatitis C medicines kind of into Medicaid, so we had better visibility on how we were utilizing them, and we were getting them out to more folks and more docs, we thought that was a pretty good idea. I'm kind of a broken record, but I like to say that don't do something because you think it's a good idea, do because it is a good idea. And the only way that you can do that is you have to actually want to know the answer to the question and ask the question and then answer it. So we did this, and then we asked the team, our really cool new data and analytics team, hey, can you go back and see if this thing that we did, our policy change, which was pretty simple to do, we just took Hep C treatment back into our internal program and see if it worked. And they said, well, that's a really interesting question. We actually have to change the entire infrastructure of how we look at this data in our warehouse because it doesn't come out clean. And so they did some incredible work. And you're seeing this for the first time, which is what happens when you ask a question on a policy change and then look to see what you did. So our first slide is our cost. So if you look so the line is pre-implementation of our policy change for hepatitis C carve out back to Medicaid. We lowered the monthly cost of treatment dramatically. This is a relatively dramatic slide, but the more important is, like I said, the simple way to lower cost is to exclude folks from treatment, right? That's the simplistic way. You spend less if you pay less. We also, we don't have it in there, doubled the number of individuals that we treated by making this medicine more available and by having the visibility into how it's spent across the state. So incredible improvement in a policy that then lets us think about, well, are there other complex disease processes or complex medicines that we should manage internally as well? Because this is a big policy statement. It seems like kind of a small deal, but we love managed care in Indiana. We think it's fantastic because it allows us to partner with private companies to deliver healthcare to folks, and it allows them to look at those individuals as a whole person, whereas Medicaid in general is a very transactional service and has been historically. So Indiana actually is about 80% managed care. We have about 20 folks left in kind of your traditional fee-for-service Medicaid programs. But part of managed care is managing the whole person, and pharmacy is a big part of that. And it turns out that in general, that's the right approach, is to make sure that individuals get not only their health care, but also their care coordination and their pharmacy benefits all in one package. But in some subsets, it's not the right answer. But unless we look at it, we won't know where those subsets are. And this is a great example of how do you take a policy, do iterative analysis, and find out, hey, you know what, this is the right thing to do in a little bit different way. So I don't want to manage your amoxicillin, but I sure do want to manage your antiviral medicines for Hep C. So really exciting stuff that comes out of the work when we look at policies, and the idea is let's look at every single one. Let's have the infrastructure to look at every single one and make sure that we're doing the right thing at the right time. And so really what the future of data looks like, not just for us, but for the state, for our stakeholders, for our partners, for our members, is that we have an enterprise, a culture of inquiry that we unlock our existing infrastructure, an incredible data warehouse for internally so that we make good decisions, and externally so that we understand the landscape in which we are doing business, and provide the right tools to get those insights from the analytics and facilitate, let's be partners with each other. Again, if it sits in a locked box and nobody looks at it, it doesn't do anybody any good. And going back to that ethics review, we need to do a little science. And so we are really excited about evidence-informed policy and building out programs that really secure and promote the health of Hoosiers. For the first time in a couple of decades, we're actually moving up in our health outcomes rankings. And we don't have any intention of stopping that movement forward. We can't do that by ourselves. And we looked back to Thomas Paine, who said, I think very wisely, it is error only and not truth that shrinks from inquiry. Thanks for having us today, and we will be happy to answer any questions that you might have.
So thank you guys so much for being here and for all the incredible work you're doing on behalf of all of us in the state, and really applaud you for your approach and your efforts. It's been wonderful to interact already and to see how we could escalate the work we're doing together, but to see what you've accomplished is really amazing. So just want to applaud you for that. So as you know, we are very keen on doing work together and helping each other, and we are already doing a lot of that, of course, in pockets, and have been for quite some time. We're working particularly on the opioid crisis in terms of working together with the MPH and you and your team, and we're at a point now where we've started to reconcile the same individuals across our data sets so that we can in fact do the kinds of analyses across our data sets. And we're in early days, but I think it's got incredible potential and it's incredibly important. I just wonder, from your perspective and what you're planning and working on already, if you could speak a little bit to how you see the work that we could do together being complementary to what you're already planning. What are the opportunities? What are the challenges we need to keep in mind? And if you could just speak a little bit to how we could work more closely together to have the greatest impact, that would be helpful.
Yeah, it's great. So what there's a couple of new faces at FSSA. Connor is one of them. He's not really new anymore. After a year, you're not new in state government. You're the old guy. But we have, for the first time at the agency, we also have a chief medical officer. You'd think as the largest provider of healthcare services in the state, we would have had one of those before, but we didn't. And so we're really lucky. Dr. Dan Rosiniak is our CMO. He's been with us since August. And also as a former NIH-funded researcher. And one of the projects that I handed to him in his job description was to make the one-off accidents of working with academics the norm instead of an accident. And so he really has made some great early steps into exactly what you're talking about, that instead of you trying to figure out who the right person is to talk to do this project, that we've got an existing infrastructure, a basic agreement globally, not just with Regenstrief or Purdue or IU or School of Public Health, but really an umbrella that allows us to have this formalized partnership across research in the public sector. There's actually, well, there's an organization for everything. It turns out there's an organization for this as well. There's a state academic partnership national group. There are 22 states that do this already. We've looked to the Massachusetts and Ohio models. We love them the most. My counterpart in Massachusetts, Mary Lou Sutters, is an absolute dynamo, and she has become a dear friend. And the work that they do in Massachusetts to really build out the academic arm of the evaluation and policy work in the academic sector is really compelling. Ohio does that as well. And what we want to do is make sure that that process is not limited to, again, small pockets, but that we really are harnessing all of these incredible processes that exist across the state. So more to come on what that looks like. We are really in the infancy of the concept, but I'll tell you we build out use cases for everything that we do. And the Jen use case on this is that I don't ever want to write a contract that has an evaluation component that goes out to a vendor, and then the report that I get back that I've been waiting for stinks. And I can't do anything with it. I really want the robust eyes on the prize of hey, did our Hep C project work or didn't it? And how can we move a little bit faster than we've been able to in the past in the evaluation and the idea generation that happens when you get more brains in a room around good stuff. What you have to do in order to do that is, again, I think I mentioned it before, is not be afraid of the answer. If you're afraid of the answer, you won't ask the question. And we're in a really good space right now that we really do want to know what are the answers. And so it makes it less frightening to ask the question. Quiet group. Yeah.
You mentioned that the opioid dashboard was going to become available. When might that be?
So the public-facing piece of the opiate dashboard should be ready by summer, and it'll be on the Next Level Recovery website. It's really, I think, going to be an incredible tool for local groups to understand. We've gotten this feedback from, really, honestly, the largest group has been mayors who say, hey, you come and tell us we have a problem, but we don't know, we don't see it, we're not exactly sure what to do. And so can you push this information out to us in a way that we can digest it and really build our community coalitions, specifically in the areas of prevention. In the opioid epidemic in particular, we know what the right emergency interventions are and what the right treatment building capacity plans are. Those are done, we just have to get bigger and better. The prevention bucket is a little bit less tangible and has to be more locally driven, because you can't swoop in and say your prevention service should look like this. And so we're really excited about partnering with local communities to make this information available and make it easier for mayors to tell the story and all of those groups about what's happening here in our town, in our county, in our community that we can do something about.
So has the Management Performance Hub had an opportunity to really kind of streamline the way that partners might request data from them for sort of scientific purposes, or is it still kind of like a one-time?
It's a great question. So the question, if you didn't hear it, was how's MPH doing on its visibility and accessibility to outside partners? And so I would say we're still in a little bit of the clunky stage. Connor, would that be appropriate? So better than when we started. So MPH was born in the fall of 2014. So it's still relatively young in its outgrowth, and it had to go through some developmental phases. I'm a pediatrician by training, so I have to use developmental phases. But the initial phase was, give us your data, we promise we won't give it to anybody. And so that you have to do that with state agencies, because we're afraid of going, we don't look good in orange, and so we're afraid of giving people information and then getting in trouble. So that first phase was building the bunker of, okay, give us your stuff, we're going to take it, we're going to protect it, and it's going to be fine. And so, check the box. The next phase was, okay, now that we have it, can we do something with it that actually makes some sense? And so the first project was in mid-2015 with infant mortality. And it was, okay, we're going to take a bunch of different data sets and we're going to squish them together and we're going to see if they can talk to each other, and then we're going to have it spit out some information and see if it's true. So it wasn't really meant to change infant mortality, but just to see if the data could actually work together. And it came together and spit out a report that said, hey, if you don't get prenatal care and you smoke and I can't remember what the third thing was, then and you have Medicaid coverage, those were the three things, then you have this higher risk of infant mortality. And everybody looked at it and said, well, we know those three things are true, it must work. So check that box. And so then the next was the sort of enterprise entrepreneurial approach to MPH. And that's sort of the phase that we're in right now, which is come to us, stakeholders, tell us what you need, and let's see if we can give it back to you. And that's not done yet, but that's the part that's really driving the work that we're trying to help MPH. We're their biggest customer. We give them the most information. And so we're working together to try to make us less clunky and MPH less clunky for those that are trying to interface with us. And then the next phase is just, I think, which is the stabilization adulthood phase of, this is just how we do business, that it's not new and shiny anymore. It's just the norm of how we get our work done every day.
Hi, Jen. This is, of course, incredibly exciting and you do a very compelling job of presenting it. My question is about something that I've found challenging up to this point, which is investigators are often driven by problems that they have seen, issues that they recognize as a problem, either because they've thought of it themselves or they've read it in the literature or whatever. Do you foresee a mechanism by which your academic partners could propose research ideas that might lead to policy changes in the future?
Yeah, that's absolutely the right approach. This has to be a bi-directional work. Talking to Mary Lou Sutters, who I mentioned before, HHS Secretary for Massachusetts, theirs is very one-directional. So it is government tells academics what they want and then gets it back, and then there's not a lot of exchange. I think what we're looking to is a little bit different than that, which is, okay, we've got some problems that we see. Can you help us solve them or do evaluation? But also, hey, we're not necessarily out everywhere all the time. Can we have a mechanism for that use case that gets submitted and ends up in the queue of, okay, wow, this is actually really important. So that really bi-directional communication, I think, is critical for how this works, but not just in the future, but really today. A lot of the things that we look at right now are actually stakeholder driven. And I think when we think about stakeholders, academia has not traditionally been at the table. So for example, I came directly here from the Medicaid Advisory Committee meeting. And the stakeholders that are part of the MAC are associations. So the dentists and the osteopaths and the psychiatrists and the EMS directors and the disability providers are all at that table. And we do a lot of work based on their observations of what's not working. But that addition of that voice of our research community, I think, will be critical in making sure that we're making good decisions and looking at the right stuff. One of the other things I'll just throw out there as we close is that the voice that we've really been missing at the state level is the voice of our member. And if we say and write down on paper that our North Star is individual and community health outcomes, we have to hear from our members about how we're doing as well. And so for those of you who do community-based research, your position and your inputs are really going to be critical to us. We're building out member advisory committees within each of our programs. So a Medicaid member advisory committee, a SNAP member advisory committee, a TANF member advisory committee, and aging, so that we've got the voice of the member unfiltered. But the voice of the member unfiltered gets us an anecdote, which is powerful. But what we also need is the voice of the membership through what that community-based participatory research and those types of paradigms look like. So for those of you who love that stuff, which I am one of them, keep doing it and make sure that you are being engaged with those types of feedback loops so that we can, again, keep getting better at what we do.